So I have placental abruption versus placenta previa, and I have abruption on this side and previa on that side. So what placental abruption is it's separation of normally implanted placenta before delivery of the fetus. And after separation, bleeding occurs in the decidua basalis, and a result of this is an expanding hematoma, which reduces the surface area for respiratory and nutrient exchange, and increases the risk for hypoxia and even sudden fetal death. Placental abruption is also known as premature placental detachment, and it occurs in 1 out of 120 pregnancies and accounts for 1 out of 10 premature births. There's two types of placental abruption. There's retroplacental abruption and marginal placental abruption. Retroplacental abruption is the rupture of the spiral arteries and is also known as a high pressure hemorrhage. And this is caused by hypertension and vascular disease, and it occurs between the placenta and the uterus. There's also a marginal placental abruption, which is also known as a subchorionic hemorrhage, and it is the most common type of placental abruption. And it occurs with tears of the marginal veins, and it's a low pressure bleed. This arises from the edge of the placenta and dissects beneath the placental membranes and is associated with little placental detachment. Signs and symptoms of placental abruption is uterine irritability, abdominal or back pain, preterm labor, fetal bradycardia, fetal demise, or vaginal bleeding. In retroplacental abruption, if bleeding remains retro, vaginal bleeding may not occur. In marginal placental abruption, women may continue to bleed after the initial hemorrhage when blood tracks behind the membranes and through the cervix. If it is older blood, the older blood will be brownish in color. Sonographic appearance for placental abruption. Ultrasound is not a huge help for acute abruption since the hemorrhage may be isoechoic to the placenta. Normal area between the placenta and the uterine wall is hypoechoic, and it's 1 to 2 centimeters thick. So if the area there is greater than 2 centimeters, placental abruption may have occurred. If the bleeding is recent, a thin echolucent area between the placenta and the uterus may be visible, or there may be no signs at all. Color Doppler is a big help for this. If there's a clot, there's no color. So the sonographer should always sweep through the whole area looking for that color flow. In retroplacental abruption, initially there's thickening of the placenta, and if it is older, it is hypoechoic to the placenta, so you should always look for the separation between the placenta and the uterine wall. Risk factors for placental abruption is maternal hypertension, prior abruptions, short umbilical cord, uterine anomalies, myomas, abdominal trauma, placenta previa, tobacco use, and cocaine use. Recurrence for placental abruption is 5 to 16% in subsequent pregnancies. Diagnosis: a physician will usually do a physical exam to feel for uterine tenderness and rigidity, blood and urine tests also, and then ultrasound to look for the actual hemorrhage. There's not much they can really do though. For treatment, if it is early and the baby's doing okay, they'll probably just hospitalize or put her on bed rest, and if it is late, they'll probably just go ahead and deliver. Overall, the prognosis isn't great for placental abruption because it is life-threatening for the mom and the baby. The mortality rate for this is 20 to 60%, and it accounts for 15 to 25% of all perinatal deaths. Moving on to placenta previa. What it is where the placenta covers the internal cervical os and prohibits delivery. It is the main cause of third trimester bleeding, and it occurs in 1 out of 200 births, and also known as a high-risk pregnancy. Placenta previa should not be diagnosed before 20 weeks. Before 20 weeks, a complete previa may be noted in 5% of second trimester pregnancies, with 90% of those resolving by term with the growing and the changing of the lower uterine segment. A C-section can be planned after early detection. There are 4 types of placenta previa. There's complete or total, where the placenta covers completely of the internal cervical os. There is partial, where only some of it covers. There's marginal, where the edge of the placenta extends up to the cervical os, but it does not cover it. And then there's low lying, where it is within 2 centimeters of that placenta, or of the cervical os. If it is low lying, they'll follow up at 32 weeks to see how much it's moved or if it's moved at all. The rule of thumb is if the placenta covers the cervix, but it also reaches up to the fundus in the second trimester, then previa will probably resolve. But if the edge covers more than 15 millimeters, it probably will not. There's also vasa previa, where it is rare, and it's where the umbilical cord or vessels are presenting, and it is associated with a velamentous insertion or a sexcentriate lobe. Signs and symptoms of placenta previa is painless, bright red vaginal bleeding in the third trimester. 25% of these experience blood in the first trimester, and 20% experience premature uterine focal myometrial contractions. Complications of this is preterm birth, maternal hemorrhage, an increased risk for placental invasion, increased risk for postpartum hemorrhage, and intrauterine growth restriction. Or if the internal os dilates with labor, there's a significant risk of detachment, which lead to hemorrhage, no oxygen, and no blood supply. Sonographic findings of placenta previa. We use ultrasound to visualize the placenta and be able to determine where it is exactly. So always describe the location of the placenta in relation to the internal cervical os. If there's an overdistended bladder, it can look like a low-lying placenta, so make your patient empty their bladder and then re-scan them again. If the fetus is presenting cephalic in the third trimester, examine the fetal head in relation to the posterior wall of the uterus and the mother's sacrum. If that distance is less than 1.5 centimeters, then there will be no room for the placenta between the head and that posterior uterine wall. And if you have any questions about where the placenta is lying, you can also try scanning transvaginally, transperineal, or translabial. Risk factors for placental previa is advanced maternal age, smoking, cocaine use, prior previous multiparities, abnormal fetal lie, multiple gestations, prior C-sections, uterine surgery. Diagnosis of this is really just ultrasound. Treatment for this as well, there's not much they can do. They'll probably do bed rest and frequent hospital visits. If the bleeding cannot be controlled, C-section will probably go ahead and be done. Physicians may also advise women with placenta previa to avoid intercourse, limit travel, and no pelvic exams. For the prognosis for placenta previa, there's a 3 to 4-fold increased risk for neonate mortality and morbidity rates from preterm delivery. There's an increased risk of preterm birth, lower birth weight, lower APGAR scores, and a higher respiratory distress syndrome. 90% of previas are resolved, but if not, there's a higher risk of massive blood loss, higher risk of hysterectomy rates, higher risk of blood transfusion, injury to nearby organs, or even death. So in my pictures, I have a little diagram right here, and it's got bleeding down near the cervix, and then it's got bleeding up on the top. So this is the retroplacental abruption because it's kind of behind the placenta. Down here is the gross pathology of placental abruption. So this is like normal, healthy placenta right here, and then this is the abruption over here. It's just really gross looking. These are sonographic images. You can't really see it, but here's the fetus, and then you can see normal placenta right above it, and then right above that you can see a hypoechoic area on the anterior side, and that is actually the abruption or the hemorrhage. Down here you can see your placenta right here, and on the side of it, all of it here, there is an abruption, and they actually measured it, and it's about 3 to 8 centimeters, or 3 by 8 centimeters. Over here we have sonographic images of placenta previa. So here's your internal cervical os, and your cervix is right here, and the placenta is covering that right here. Same thing here. There's your internal cervical os, and your cervix is all right here, and that placenta is covering. This is gross pathology of a uterus, and you see you have the whole uterus right here, and you can see the placenta right here is covering that cervix, and then you have a umbilical cord right there. And this is just a little diagram of complete, partial, marginal, or low-lying placenta. So that's it. Thank y'all.